Let's review the evidence linking medial entry for trochanteric fractures to osteonecrosis.
So the big question is, just how real is the vascular risk with a medial entry point?
Okay, first up, let's talk anatomy. Why are we even concerned about this in the first place?
It all comes down to the medial femoral circumflex artery. That's the key vessel we're worried about. And we know from cadaver studies that a medial, or piriformis, entry can definitely damage its branches.
And that right there is the core reason we worry about causing iatrogenic avascular necrosis, or AVN.
So that's the theory. Now, what does the clinical evidence actually show in our adult patients?
And here's where it gets interesting. There's a real disconnect between theory and what we actually see.
In reality, the AVN rate in adults is incredibly low. We're talking less than 1%.
Yeah, population studies just don't show a strong causal link in adults. The signal is weak.
So for this group, choosing a medial entry doesn't seem to reliably predict AVN or union issues.
But the story changes when we look at certain high-risk patient groups. The evidence is different here.
For skeletally immature patients or those with femoral neck fractures, the risk profile really changes.
You can see it laid out here. The risk jumps way up for kids and femoral neck fractures.
In these groups, the clinical findings actually line up perfectly with that anatomical concern we started with.
All right, so what's the bottom line? How do we put all this evidence into practice?
Okay, here are the 3 big takeaways you need to remember for your practice. It's pretty clear.
So, given all this, how will you weigh theory versus technique in your next case? Something to think about.